The plan for the next hour and a half is to have a panel discussion of working and successful models to deal with opioids in the emergency room. And we have 4 panelists who will each speak for about 10 minutes, and then we'll have a full room discussion for about half an hour. Looks like we have all the people up here, so...
+1, because I've invited Marcia to co-present with me. It'll be a much more interesting presentation if she joins me.
Okay. So I think you have name tags for. Go ahead and sit down.
No. I'll sit in.
And
Back up.
our first presenter is Chris Ringwalt, and I'll quickly. So Chris is a senior scientist, Chapel Hill Center of the Pacific Institute for Research and Evaluation at the University of North Carolina Injury Prevention Center. And so he's going to speak about they're both going to speak about the North Carolina Emergency Department Care Coordination Trial.
That'll be fine. So I'm Chris Ringwalt. I'm a public health guy. I'm not a real doc, as my son kept reminding me as he was coming up. But I got interested in this whole area in part because of my esteemed colleague standing behind me, with me, Marcia Ford, who will join me in this presentation. And Marcia has lots of distinguished credentials that she could share with you. Marcia, just do 1 or 2. Don't keep this here all day.
I'm an emergency physician.
Oh, wow. And oh so much more. So the title of this presentation is A Randomized Controlled Trial of an Emergency Department Care Coordination Program in the Carolinas Healthcare System. That's quite a long and cumbersome title. I'm not sure that it's terribly descriptive of what we have done, and I couldn't think of a better one. I'm still in search of it, but if you boil it down to its essence, it really is a plea to high-risk, high-flyers who come to EDs. Please, we know you're in pain. We are concerned about you, but this is not really the right place for you to come. Please go out to your community-based provider and seek help there. Now, how to boil that down, how to distill that down to a more descriptive title, I don't know. At any rate, yes. So here are our colleagues, the ones who are here whom I'd like to stand up, and so I can introduce them and express my great appreciation. This has been a real collaborative effort. Stephanie Wodowski on my right and Angela Fusaro on my left. And they all stick around and help answer any questions that we don't do a very good job with. I'd also like to acknowledge Len Pelosi, who of course isn't here for reasons everybody's acutely aware of, from the Centers for Disease Control and Prevention. He has been wonderfully supportive of us and a great guy, an extraordinary resource, and if you're interested in this area, I do connect with him. Okay, I don't really feel very much like providing you with an introduction because this whole day has been an introduction so far to the topic that we are discussing. But I will say that to reduce costly and time-consuming incursions into EDs by patients who should not be there, particularly chronic non-cancer pain patients, EDs all over the place are developing guidelines for the treatment of chronic subjective non-cancer pain, and they're implementing care coordination plans to manage their patients. This is being done in North Carolina. I would imagine that this is growing up like weeds everywhere, and I think it is a very good thing to do. None has been evaluated yet by a randomized controlled trial. You'll be hearing from me from our trial in North Carolina. You'll be hearing from our colleague Darren Nevin about their trial and here in Washington State. Okay, so this is what the intervention is all about. And the providers are consented to participate, but the subjects of this trial are not. We indeed got a waiver of patient consent. We did so for a variety of reasons. Our justification was, well, if we had to consent the patients, none of them would have signed up, or very few of them would have, and we would not have had a trial. But also, the protocols that I will describe shortly explicitly tell the provider that he or she should follow his or her best clinical judgment in responding to patients presenting problems, and that trumps any of the advice that we give them.
If I could just say a couple of words about this. There are four standards that you have to meet in order not to consent a patient. We met those four, and we met them both at the UNC Chapel Hill IRB as well as the Carolinas Healthcare System IRB. So I just want to throw that in, that this was approved by two independent IRBs.
But the kicker for us was, we are trying to change provider behavior, that is your behavior, not the behavior of the patients themselves, ultimately. We should also let you know that we did not tell, again, with the full approval of all participating IRBs, tell the patients they were participating in a study as such. But those who were randomly assigned to the intervention group were aware of the study's protocols. So, the intervention comprised a letter that we mailed to the patient at home, which included the guide to local community-based providers. A copy of this letter and a letter to their providers that we also sent, and a copy of the flag that we placed in the electronic file of patients enrolled in the intervention group. They're all in your packet. As far as I'm concerned, they're all in the public domain. Personally speaking, I don't know that you need to attribute anything to us if you use them in whole or in part, but I would like to see them out there if you think they are useful. Okay. So the flag informs providers that a committee of hospital healthcare providers have noted that the patient has made numerous visits to the ED to control chronic pain, that the committee has recommended that the patient seek treatment from their community-based provider or pain specialist and not in the ED, and that the provider should not prescribe opioids for chronic subjective pain, should follow standard practice for acute pain, and that the clinical judgment, as I said, of the provider will always supersede the recommendations in the electronic flag. The study site, and this has been and continues to be a terrific collaboration for us, I am blessed, is with Carolinas Healthcare System, which is the second largest public healthcare system in the nation by number of beds. And it comprises 13 EDs with linked electronic records. And this gave us a very large set of EDs that we could include in the study, and which yielded a great deal of power to find differences. And this was also a blessing for us. So the study objectives are to examine whether the intervention reduced the number of visits these patients made to these constituent EDs, the number of visits these patients made to EDs related to opioid overdoses, the number of prescriptions for controlled substances written for these patients upon discharge from the ED, and the costs of these visits. I'm talking about the first and third of these four goals today. The costs of these visits, well, we may or may not ever get there. It turns out the cost data available to us at the moment look like Swiss cheese. So if we can't get the rest of the data, and Stephanie's doing her best to get it for us, we actually won't know the cost savings incurred, which would be a shame, but it's the nature of research. You do what you can. So the eligibility for the study, inclusion criteria included age, 18 to 90, I think it was, something of that, but adults, at least 11 visits over a 12-month qualification period, 11 visits over a 12-month qualification period, and at least 2 of these visits had to have a discharge code of back or neck pain, headache or migraine, arthritis or joint pain, chronic pain syndrome, or generalized pain. and at least one ED visit within the last 120 days. We wanted to weed out those who had migrated out of the state or at least out of the area so that they would not clutter up our study with basically useless information. We had a number of exclusion criteria which I think are very important. Any diagnosis for cancer other than non-melanoma skin cancer, sickle cell anemia, and suicide attempts or suicide ideation. We heard earlier today about patients who leave suicide notes saying, I'm in chronic pain, it's not being treated to my satisfaction, my life isn't worth living, and who then commit suicide. We wanted to avoid this, and we successfully did. As far as we know, we kept looking for any evidence of any of these three exclusion criteria, and particularly suicide attempt or suicide ideation, not only in discharge diagnoses, but also in any of the text related to visits to the ED. And God bless Stephanie for going all the way through these and preparing summaries of the key and pertinent information on each potentially eligible patient. It was highly labor-intensive, a real labor of love, but we believe we have successfully weeded out of our patient pool patients who should not be there because indeed they are actively considering suicide.
And I just want to make one correction to this slide because the May 2012 to July of 2013 was the actual active period of the study where the intervention was applied. For the purposes of determining who was going to could be included in the study, it was from October of 2010 to September of 2011. But it was a 12-month period, and again, as Chris said, the patients had to have at least 11 or more visits to one of these 13 emergency departments in order to be potentially included in the study.
Final eligibility for the study was determined by a multidisciplinary review committee of 8 providers representing a number of different specialties at the hospital, including dentists, pharmacists, and an orthopedist, who reviewed Stephanie's chart summaries. Then they voted in private, and they discussed non-unanimous decisions in committee, and a majority vote determined enrollment. So that resulted in weeding out a number of people whom the committee said, okay, the exclusionary criteria are such that they should not be enrolled in the study because the intervention could legitimately damage them by preventing them from having a medical response to their legitimate pain needs. And next I want to show you a simplified consort document for those of you for whom that means anything. Assessed for eligibility were 762 patients. We weeded out due to various reasons that I'd be glad to go over if any of you have any questions later. A number of them. We randomized 411. We then allocated to the intervention group 205 and 206 to the control group. And then we excluded a number of these post-randomization because they tripped our ineligibility criteria, cancer or sickle cell disease, or because they developed or manifested suicide ideation. But we did, and we were allowed to keep their records up to the point at which we excluded them. So we can do survival analyses for those who, say, were in 2/3 or 1/2 of the intervention period to determine its effects on them for the period of time that they were there. So excluded means excluded only up to the time that they presented an exclusionary criterion and then were released from the study. Now we took a very close look at the effects of randomization at baseline. I've done any number of randomized controlled trials, and I have been often disappointed at their effects. In this case, we failed to achieve equivalence yet again, and you will see for race, we had an imbalance in there. We had a trend towards imbalance in gender. I'm moving along more quickly than I would like, perhaps, but we'll get to the meat of this in a moment. And There was also an imbalance in prescribed controlled substances per visit in the intervention and control group. I think it's terribly important to do all these things because it gives you an idea of what you need to control for later in your analyses. There's a great deal of argument in the research literature as to whether you should or should not control for unbalanced covariates in randomized controlled trials. I'll spare you the discussion. I think it's tedious. I think if you didn't achieve equality, why, you should control for where you didn't achieve it. So that's just my personal bias. We did, and by the way, it didn't make any difference because our results were so salient. Okay. So here are our findings. What you see is a substantial difference between intervention and control patients, both for ED visits and for prescribed controlled substances per visit. Substantial, 11 versus 16 in the intervention versus the control group. Prescribed controlled substances per visit, 0.23 per visit, about 1 in 4, relative to about 1 in 3 for the control group. These are big differences. Tests of statistical significance are, I think, irrelevant. This has great practical significance for the work you're doing. These preliminary data indicate that we achieved exactly the effects that we anticipated. So, moving on to discussion and then a couple of limitations. These preliminary findings suggest the trial was successful. Generalizability may be limited for at least a couple of reasons. One of them is that the costs associated with this collecting all of the data and then running it through this interdisciplinary committee were substantial. In fact, we don't plan to calculate them, but if there may be a way to streamline this for other EDs that might care to adopt this intervention, but we wanted to go the extra mile to be extremely careful that we did not enroll any patients who should not have been there. So that's the cost issue. The other reason that there's some concern about whether this can be easily replicated is that if you can imagine the high flyers that we enrolled in the study, they were at the very top of a very tall pyramid. And these were the patients who had the most egregious behavior over the eligibility period, and so the ones that we could make the greatest difference to in our study. Other EDs are unlikely to show as much of a dramatic difference as we did if you have fewer numbers of high flyers. But still, the principle of the results we found stand. Also, the patients in our study had options. They could always go across state lines. And then to other EDs. They could go across the street to Presbyterian Hospital in Charlotte. Some indeed shuttle back and forth between the EDs that basically face each other and get their needs for medication met there. So we really can't control for that, unfortunately. But what we can do and will do is go to North Carolina's prescription drug monitoring program and see if patients in the control group are more likely to go off to other places in the state or in their community to get the substances they're looking for. And you'll hear more about that when Darren talks next.
We're going to have to move on.
Okay.
So great presentation, great study. Thank you very much.